My name's Patricia Snell. I'm here with some of my colleagues from Guy's and St Thomas's Foundation Trust in London to share some of our reflections with you about hosting our experience day looking at care of the older person. I'm just going to introduce some of my colleagues. Chris, can you tell us
Dr. Chris Bollen. I'm a general practitioner from Adelaide in South Australia, visiting my first forum, and certainly it was my first visit to Guy's and St Thomas. Looking forward to understanding the care of the elderly.
Adrian Hopper, I'm one of the geriatricians at Guy's and St Thomas's Hospital, so I was one of the organisers for the session.
I'm Steve Waters. I'm one of the clinical governance managers at Guy's and St Thomas's, and I was heavily involved in the general organisation and the way it worked.
Hi, I'm Alice Oborne. I'm consultant pharmacist for safe use of medicines, and I ran one of the workshops that was presented at the Experience Day.
And I'm Mark Kinirons. I'm one of the consultant geriatricians, and I also ran part of the session during the day.
Just to begin, can I ask Adrian and Mark to give us a bit of background about what we did on our Experience Day, the types of workshops that we held, and a bit of background about the care of the older person in Guy's and St Thomas's.
Thank you, Patricia. Well, at an international forum a couple of years ago in Amsterdam, I'd gone to an Experience Day at the Medical Centre in Amsterdam, and for me it was the best part of the conference to actually see similar problems managed differently. So when the BMJ approached us to say, as the forum is in London, could you look at hosting an Experience Day, I thought, what an excellent idea. And obviously it has to be, we felt it should be on a clinical theme rather than the hospital in general. And we are both proud, but have a lot of innovations that we thought people coming to the forum would be interested in hearing about on care of older persons. So we sort of early on felt that should be our main theme. So we ran it, and then the second discussion, because the delegates coming to the forum like to argue, talk, work in workshops, is we chose to not just have people in a lecture theatre for the whole day listening to us talk, but to combine some of that with some themed workshops. So we tried to cover the breadth in terms of both the problems but also the innovations in British geriatrics, and then particular themes which were about our local innovations were in use of simulation to improve the quality of teamwork, so team-based simulation. Some work we've done on developing a care bundle for managing patients approaching the end of life, the Amber Care Bundle. A film that we're using as an organisation to train all staff about the experience of being a patient with dementia. So far 10,000 of our staff have been in sessions discussing this linked to a film called Barbara's Story, a workshop on medicine safety, a workshop on dementia and delirium, and finally a workshop from some of our very innovative work on use of liaison geriatrics as a model of care and a standard of care within the hospital for older persons, both in the medical service but also in oncology and surgery. Mark.
I mean, I think to add to Adrian's comment, we've been to a couple of forums over the last few years, and what's striking, of course, is in terms of patient need, it is an older population, and yet the forum and the IHI, to a degree, have not been, I guess, promoting or pushing an older person's agenda. So we were fortunate enough last year to be invited, and in a sense, this is almost part of, let's say, our aspiration to influence the organisation, to focus some of the forum on older persons' needs as it relates to all aspects of care. So Steve can comment from his experience and as a GP later, but clearly it's focusing on this large, expanding section of the community seemed to many of us around the table important for the IHI and the BMJ. So I think it was on that pretext that we were able to, if you like, make a representation to them, and glad that they were able to, invite us to come back. So.
Okay. Alice, if we go to you, give some reflections about how you felt facilitating and leading on one of the workshops, and a little bit of background about that workshop that you led.
Thanks, Patricia. So it was really interesting receiving comments. We ended up with a very interactive workshop, particularly the people whose English was their first language were, jumping up and giving their opinion and commenting on some of the innovations we were presenting. So people clearly enjoyed it. It was an honour for me and for Guys in St Thomas to be able to showcase some of the work that we do for sort of multidisciplinary medicine safety work for older people, medicines in particular for older people where they receive more medicines. The ageing population of the UK is getting older, and so we were able to show some of the electronic changes that we've made, some of the services around multidisciplinary services that we offer where pharmacy staff, doctors and nurses work very closely.
Okay.
Can I just ask Alice to give us her feedback around one of the areas we've worked hard at in a multidisciplinary practice is opioids, and of course, and Shaheen Khan, who was a colleague of ours, was there. How do people respond to, say, some of our innovations around opioid safety? Was there any kind of useful feedback from what you presented or discussed?
So we don't yet have electronic prescribing, so we're able to talk about some of the controls that we have on prescribing. For example, an opiate patch, there's a risk that the patient will be left with a patch on, or that the first patch won't be taken off, or if the nurse is interrupted while they're changing the patch, the first one. So it's very clear now that you prescribe it in a particular way, prescribing off first in case you're interrupted when you're changing the patch, and then prescribing, putting on again, and drawing a line through the days that you don't want the dose to be changed. So we talked about the safer by design and safety by design for opiates that we've put in place, and people like that. We also talked about sort of protocolized stuff. So we have made it that you must prescribe by generic, even specified the release formulation, and that took a while to change, but it's been widely adopted. I think that's quite different to what's in practice in other countries.
Okay. Chris, you've travelled a very long way to come and spend some time in Guys and St Thomas's. Could you give us some reflections about your experience of our Experience Day?
Sure. Certainly, I think the thing that impressed me for the whole day was that the commitment of the team to really want to improve the care of the older person. And so as a GP working in the community in Australia, we don't often get to meet too many of our hospital colleagues, and many times we hear about disjointed systems and just not people working in teams. But I was really impressed that this commitment to making the care of an older person a high quality experience. So it's something I'm going to take back to Australia to say, look, it does exist an interest in better care. My area of working in the community and in residential aged care facilities, such that some of the things that Alice was mentioning about improved medication safety can be immediately transferred into residential aged care facilities, the same process of checks of opioid patches. So that's going to be a recommendation I'll take back. The stories about change within the hospital, the whole culture of care, based on Barbara's story, the 13-minute DVD from the chief nurse Eileen was particularly impressive, of how to actually influence people at all different levels within a hospital to actually make little things different. And I noticed that in my own patients in Australia, when they visit public hospitals, they come back with terrible stories. And the fact that staff care can make a huge difference. That was very impressive. I think the other area that was fantastic to see was the simulation training, essentially getting staff to actually feel what it's like to be getting older. I tried on the ageing suit and the goggles to give me the tunnel vision and the lack of mobility and the sense of edema of the legs. And that was a really revolutionary experience. And I think that for all staff in hospitals that care for older people, as well as in the community, because that's where a lot of the care is actually being delivered, to understand what is required to deliver little bits of care, feeding. So I thought that was fantastic. I'm going to take that back to Australia. I actually already sent a photo back to my team to say, I think we should be doing some simulation, low tech, but very, very tangible, with our doctors and nursing teams in the acute hospitals. So that was a very much a highlight, and the fact that you've got the the guts to close a ward for 2 weeks to actually get your staff trained was, I think, a real innovation as well.
Okay. We had a workshop on a development programme on some of our older persons wards. Would Mark or Adrian like to tell us a bit about that workshop and what we did about training staff to have more empathy and the whole leadership issues and using the simulation dummy and the ageing suit and the impact that that has had on our doctors, nurses and the allied health professionals and wider team that work in those wards?
Just to put it in the context, because this was as you allude to, a workshop which we did about a year or so ago, driven by a need to look at the quality of care, driven by patient feedbacks, there were some concerns. And so the ward closures that Chris alluded to described our first attempt at looking at simulation and taking people out of the clinical area as a method to challenge them around certain aspects of care. And so out of that we learned, which informs then the workshop that we had in the programme, was a focus on some of our learning around how to engage all staff. And the suit is an amazing thing. Likewise, to think, to imagine and to put yourself through it gives you some different perspective. But even softer things where I was impressed in preparing for the experience day, as well as having participated in the breakout a year or so ago, was actually in the ward setting, getting to know every staff member, and that includes, of course, the house and domestic staff, who, of course, are crucial to providing food, yet commonly may be considered as the least skilled staff. Yet, in many scandals in the NHS and around the world, it's my mother went into hospital and starved. Yet, so if we can engage that staff as part of a ward culture, I found that really particularly impressive. And I'll tell you one interesting story. If you go into many wards, you'll hear staff, of all professions, refer to patients, the patient in bed 14. And one of the challenges that we had that's emerged out of my own thinking, if you like, one of the things, what will I take home from today, from our experience day, that emerged from the breakout was, we already know who patient 14 is. It's Mrs. Bird, because we all talk about Mrs. Bird, all of us. So why not let everybody say, what does Mrs. Bird want for breakfast? Oh, it's cornflakes. Let's get cornflakes. Rather than this numeric, impersonal, and of course that's easy to do, costs nothing, yet sends a signal. And one of the lessons I had learned out of the simulation kind of approach.
Okay, Adrian?
The other thing just on the simulation is it was evaluated. That was partly as an academic centre we're interested in that. But therefore we do have feedback, and I remember in a sort of debrief seminar about 9 months after the work had done, one of the physios in the ward saying the teamwork and the quality of communication between teams is still unrecognisably better. So it's not just that it had an impact, it was the sustained impact. And you saw that data, Chris, on fracture prevention in the wards. Actually, that was the first time I'd seen that data. And but what it shows is a sustained reduction in fractures on the ward. In other words, a better sensing and recognition.
Okay. Steve, if I move to you, could you share your thoughts on how it felt for you and the rest of the team organising the Experience Day? Because obviously others will be involved in the future, and I think you and your team learnt a lot and were involved heavily in organising this. So some thoughts.
I think we were very conscious that we wanted to provide something that's actually an experience rather than just everyone being in one room for the whole day and being more like a conference. So it's a challenge to juggle this need to do different things and go different places with the fact that we know we had an audience of 130 people, the vast majority of whom were international, and were in a very different environment to what they might be used to. We've run a couple now of quite major 200 people plus conferences for local people, and we've learnt from that how they can get lost and they can get confused. So we were very conscious this time, especially when we were in a hospital environment that's not designed for conferences of this sort, that there was potential to go wrong. And so we put a lot of thought into things like that. We gave everyone little personalised cards as to where they were supposed to be. We heavily signposted the whole place, and we stationed some of our team around everywhere to make sure that nobody got lost, which I hope worked quite well. We also put a bit of thought into the food and the catering that we served on the day, with a sort of a bit of a British theme. We served scones in the morning and Yorkshire puddings at lunchtime and so on and so forth, to give a bit of a flavour of the environment. But mainly what I hope is that people enjoyed the day as an experience and thought, yes, we are in a hospital. We may not be seeing the wards or seeing that, but they are seeing something of what we do with the people that do it. And also I would add that the team that I'm part of, although we have done a few of these conference sort of things now, we are specialist governance, quality improvement staff. We don't organise these events, but it is quite a good fun thing to do.
So
and
you
it is
enjoyed
different,
it?
and you do meet a lot of different people and you do learn a lot, so yes.
Good. Okay, if I could just share some of my reflections on being involved in the organisation and going to some of the workshops. I think it was a privilege for us and for Guys and St Thomas's to showcase some of the really good work that we're involved in. But I think it was also an opportunity for not just the clinicians but the non-clinical staff to learn from others and to see what others are doing on an international basis, because it's good to learn and to share. And I think the initial feedback that we have had has been extremely positive. People have learnt a lot. We've got lots of communication about people wanting more information, and I think it was an enjoyable experience, and I certainly got a lot from that. So perhaps it would be useful just to go around to finish off and to share some of your reflections on how you felt the day went, if we could have done anything better, and what we plan to do next.
Can I just, before we do that, can I ask Chris something? Because and every conference has to have the noisy person who won't shut up, who keeps asking questions, because the rest is silence. So one of the things you said right at the beginning of the day is you wanted to hear more about integrated care, and I said you will hear more about it, but we haven't sorted this out, and it's a journey, as it were. Your reflections on integrated care, how was it in terms of learning about the UK experience?
Well, I think that it was pleasing to hear that everyone was making an attempt to sort of try and understand it better. The definitions seem to vary, whether you're out of hospital or in hospital as your primary area of work. In the end, you've added something to my learning by being able to take home sort of your approaches. It all needs to start with the comprehensive geriatric assessment, which is critical to any integration. You can't understand your older person unless you have that as a basis, but you've also got to understand the teams and who's in the teams. And I think that was brought through just the simple fact of your team orientation and the importance of culture as part of integration. And your involvement of patients in the whole process. So there are a number of things that I've taken home, Adrian, that will rest with me, and I see that there is a journey for all of us to keep going on.
Well, we'll keep in touch.
But I think that, like anything, that the importance of communication. I think the day brought that which probably your average conference doesn't have. You're actually spending a whole day in a smaller group, working on different areas which we all have in common. And to actually keep talking over a whole day has been something that has actually been a great value, which many conferences don't have. So I think thanks to the organisers to actually have the foresight to say, well, look, communication in small groups makes a difference, and your learning is actually greater.
Okay, thank you, Chris. Adrian.
Well, two things for the day is, firstly, what the audience, as has been said, was largely international, and just in the teaching, in the workshops and so on, and to some degree the international forum, that's its beauty as well, is learning with an international audience. So specifically I took a seminar about end-of-life care, and healthcare staff, professionals coming from other countries, other cultures, just a very different perspective on discussing death and taboo issues of death. So it is a great, universal problems, but different approaches, different cultures. The other thing, which is, I've been turning up for work at this place for many, many years, and it's just a place you go to work, and it could be a factory. You hardly notice what's behind the walls. And when you just look at, with the eyes of possibly an international delegate, I was just astonished at the 800 years of history of our organisation, and Florence Nightingale looking around, and the great and the good, which of course includes Keats and Wittgenstein, of the alumni of this institution. So I was sort of in awe and sort of reinvigorated about the pride of working at our wonderful organisation.
Steve, have you any final thoughts?
I think it's great for the organisers, certainly for the team that we're in. Some of the staff are quite junior, and in doing this sort of thing, it gives them a chance to sort of feel the sense of pride when something goes well and it all comes off and it goes well. But also, when they're there on the day, it gives them an opportunity to both see these things in action, participate in the discussions, and talk to some very senior international people, learn a lot of stuff that they wouldn't otherwise have had the opportunity to do. And that's a brilliant opportunity for them.
Okay, thanks. Alice?
I guess one of the reflections, particularly coming from the delegates from the north of Europe, was that in Guy's and St Thomas' we have a particular emphasis on multidisciplinary responsibility for prescribing, and they took a wee while to grasp that where we were on that curve, where both doctors, pharmacists, and nurses all act as safety nets for each other in medicine's use.
Okay, Mark.
Just on the workshop that I led with my colleague Bridget Fordham, it was interesting to see a consistent lack of consistency around knowledge in relation to recognition, response to delirium dementia. Even amongst the range of international practitioners there, you clearly could see the same issues that we struggle with on the acute side were reflected in colleagues, say from the Northern Europe or Wales. There was a colleague from Wales where there is clearly a lack of knowledge. So one of the things, as was said actually today by another speaker, was trying to get some of these themes of improvement into undergraduate nursing, medical and therapy, pharmacy, school. Education is really important to nurture and develop. But more parochially, I think the experience day was a great experience. I think we all enjoyed it. It's been a pleasure to have been able to have the opportunity and the chance, as Chris said earlier, to meet lots of people from around the world. You can't beat it, because that's what inspires you. Hearing different stories, as Alice said, different narratives, and the fact that it went well, both front door as well as back door, crucially, is a kind of a acknowledgement of at least very good teamwork from our end. So that was satisfying.
Yeah,
so.
I think all of us would echo that. Your comments, Mark, and it was very hard work, but it was also really, really enjoyable, and there was a wider team involved, and I think we need to thank them and thank IHI and BMJ for giving us the opportunity to showcase all of the fantastic innovative work that we do, but also to share from colleagues across the world, because it was really stimulating to get to hear those discussions between everyone. So thank you, Chris, and thank you to the folks that spoke, and also to the clinical governance team who did most of the organisation. Thank you.
Thank you.
Thank you.